In the series of fetal ultrasound, today we will see the assessment of cervix in gravid uterus. Cervical incompetence is a condition in which the cervix fails to retain the conceptus during pregnancy, and the cutoff usually is taken as 25 millimeters. Most of the times it is idiopathic, sometimes due to congenital anomalies, connective tissue disorders where the cervix muscle is weak, and sometimes because of surgical trauma. The majority of preterm births are spontaneous and recurrence risk is high. So the history of prior spontaneous preterm birth is the strongest risk factor for the next PTB. Transvaginal cervical length measurement is an important clinical tool to identify these women at high risk for preterm birth. Short ranges from 20 to 30 millimeters in different references. Normally, we see the cervical length ranging from 30 millimeters to 40 millimeters. So, the best cutoff is 25 millimeters. So, anything which is smaller than 25 millimeter is usually termed as short cervix. So, women with the history of prior spontaneous preterm birth and a short cervical length are at the highest risk. So, whether we should measure it transabdominally or transvaginally, of course, it is considered as the gold standard because these measurements are highly reproducible and are unaffected by maternal obesity, cervical position, shadowing from fetal parts, and it is the more sensitive tool. So, how to measure this cervix? So, there are different programs, training programs available online. The important being cervical length education and review, which is called as CLEAR program, which is sponsored by Society of Maternal and Fetal Medicine. The FMF UK also has the certification course for cervical assessment. These are all available online. We will see the CLEAR guidelines or a CLEAR concept today. As you can see here, this is the diagram which they talk about when they are talking about cervical incompetence. This particular portion is taken as the funnel width when the internal os is open. This particular portion is the funnel length, and this is the closed cervical length. You should always see the image where the anterior lip and the posterior lip of the cervix are equal thickness, so that you know this is a proper section of the cervix. So what are the guidelines? It is of course a transvaginal image. You should magnify the image that it occupies 75% of the screen. The anterior width of the cervix will equal the posterior width. Echogenicity should be similar. Bladder should be empty. Internal os and external os should be clearly seen. Endocervical canal is visible throughout, and caliper placement has to be correct. How is the caliper placement done? It is done from the internal os and the external os. The cervix sometimes is curved. Then you should take 2 or more linear measurements and then add it. But you should not trace the cervical length. That is what these CLEAR guidelines say. So this is just in nutshell about how you take the cervical length measurement. These are just the steps which are described and what we saw in the previous slides. This is the image. As we saw clearly, the anterior width, posterior width should be equal. This will be termed as funnel length. This is the closed cervical length. This is the funnel length, and this is the funnel width. Then what are the types of cervical incompetence? It may be just a short cervix, as you can see in this. It may be a Y-shaped incompetence, it may be a V-shaped incompetence, or it may be a U-shaped incompetence. So as you can see here, it is the short cervix in the first image. This is the Y-shaped incompetence where this will be the funnel width, this will be the funnel length, this is the closed cervical length. Then sometimes you see it is almost like a V and it is almost open. This is the external os and the internal os is open. This is a U-shaped cervical incompetence where you don't see any closed cervical length. It is almost open. As you can see here, this particular portion is the external os. So as you can see here, it is almost a U-shaped cervical incompetence. You can see fetal parts in fact protruding here. This is the V-shaped incompetence. This is just a short cervix, but then you wait for some time. Sometimes you see the internal os opening. As you can see here, this particular portion is quite short. So you should see to it that it is the internal os and the external os are properly seen there. It is usually a dynamic kind of the situation. Cervix is a dynamic organ. So as you can see here, these images are taken just few seconds apart. But as you can see here, in fact, you feel that the internal os is closed. But then in just a fraction of a second, if you see, it starts opening up. That's why you should be always careful, and you should not just scan the cervix, insert the probe, measure the cervical length and take it out immediately. You should extend the examination for 5 minutes, visualizing the cervix. Sometimes it shows spontaneous changes and you should be aware of it. Cervical stress test sometimes is done between 15 to 24 weeks. You can just give some transfundal intrauterine pressure while monitoring the cervical length and look for the appearance of funneling. So when should you assess the cervical length? All throughout pregnancy? Well, no. It should be done between 16 to 24 weeks, because before 16 weeks, it is not predictive of preterm birth and not advised beyond 24 weeks, because the intervention what is done for the cervical incompetence or short cervix is usually done before 24 weeks. Whenever there is a history of prior preterm delivery, then all the guidelines, the SMFM and ACOG guidelines suggest that you should do the cervical length screening with transvaginal ultrasound. So it recommends a routine transvaginal cervical length screening for women with singleton pregnancy and history of prior spontaneous preterm birth. But then what about the women who come without history of prior preterm birth? That particular thing is still an object of debate, whether you should screen all pregnant patients who come to you between 16 to 24 weeks ultrasound scan with transvaginal ultrasound. At present, the guidelines say that it cannot yet be universally mandated. It is not compulsory. It can be viewed as a reasonable and can be considered by individual practitioners. But one thing is very clear. Anybody who decides to implement the cervical length screening should follow the strict guidelines as we saw in the previous slides. Is there a role of cervical length screening after cerclage? Well, sometimes you see cervical shortening even after taking the cerclage sutures, particularly if the cervical length is less than 10 millimeters, but then there are no additional treatment options for a short cervix after cerclage. Hence, there is insufficient data to suggest a clinical benefit of a routine post-cerclage measurement or a surveillance. In multiple pregnancies, well, women with multiple pregnancies, the cervix is shorter and associated with an increased risk of preterm birth. So, routine cervical length screening by CVS in multiple pregnancies is a good practice point, but again, the guidelines don't make it mandatory. There was a nice article, in fact, in 2019, they tried to see the implementation of universal screening for preterm delivery by mid-trimester cervical length measurement. They wanted to see whether it is feasible to screen all women who come to you for a routine ultrasound scan in mid-trimester. And what they implemented is the measurement at 20 to 24 weeks is feasible by a transvaginal cervical length measurement and well accepted by pregnant women, and it is not time consuming. So maybe in coming years it may get included as a part of routine ultrasound scans between 16 to 24 weeks. So what one should remember is cervical length measurement, of course, is a must between 16 to 24 weeks. It should be in fact the first image when you start scanning. The patient is sitting outside at the reception. patient has walked up to your clinic, so there is a pressure of gravity uterus on the cervix. So as soon as the patient lies down, in fact, you should try and measure the cervix so that you get the exact length of the cervix. The bladder to be partially filled, it should not be over distended or it should not be completely empty if you're doing a transabdominal scan. Of course, for transvaginal scan, the bladder has to be empty. You should always look at the referral note. You should ask the history. If there is a prior preterm birth, you should always do a transvaginal scanning. You should always look at the preference of gynecologist. Some gynecologists prefer to have a cervical length taken by a TVS route. In multifetal pregnancy, it is a good practice point to do a transvaginal examination. Patients many a times have a vague lower abdominal pain, some pressure down in the cervix or in the vagina. They have some tightness. So all these symptoms should be looked at, and then you should suspect that it may be the short cervix and do a transvaginal examination. But you should be aware of the lower segment contraction. You should not falsely label these as cervical incompetence. As you can see here, the closed cervical length is very good, and in fact what you are seeing here is not funneling. This is not the internal os. This is just a focal myometrial contraction on both the sides, and this should not be taken as the cervical incompetence. And even if you feel that this is internal os, you should look at the closed cervical length. The data says, the references say that if the closed cervical length is more than 3 centimeters, then, and even if the internal os is open, it does not really indicate the higher risk of a preterm delivery.